clinically relevant way. So it is about acute valvular emergencies. So if you take acute valvular emergencies, most of the time, the most important valves are the aortic valve and the mitral valve. So if you get acute AR or acute MR, patient is actually gets hemodynamically unstable. At the same time, sometimes tight critical aortic stenosis can present as a valvular emergency. Sometimes they can present with a cardiac arrest, or even can present with the pulmonary edema or cardiogenic shock, patients with tight A's. Similarly, tight mitral stenosis also can present with florid pulmonary edema, sometimes cardiogenic shock. And sometimes it can be the first presentation of pregnant patients. I have many patients. I'm sure almost all cardiologists, I'm sure people who are working in cardiology do have seen that. Patients with pregnancy, sometimes the first presentation can be pulmonary edema, and then later you diagnose to have critical mitral stenosis. So you have to understand, what the pathophysiology and also the way of presentation and how you are going to manage in day-to-day practice, especially the acute AR, acute MR, and tight aortic stenosis and tight mitral stenosis. So let me go through one by one. So first I'm going to talk about acute AR. So before we go to acute AR, we must know what are the causes of acute AR. So there can be problems in the valve, leaflet, and also the valve ring. As you know, the aortic valve has 3 cusps. Sometimes it can be 2 cusps, sometimes it can be a single cusp. And there's a valve ring. So when you get an endocarditis in a valve, it can suddenly perforate the valve. While in the ward, patient can become suddenly hemodynamically collapsed, like patient can become tachycardic, hypotensive in a patient who get acute AR. So infective endocarditis is one of the causes. And sometimes the aortic dissection, when you get patients with aortic root dilatation, when you get dissection, they can involve the valve ring and can get acute AR. And sometimes trauma can be associated with to the valve, can be associated with very rare, but though it can happen. And sometimes the patients who have had valve replacement, like mechanical aortic valve replacement, suddenly post-op, even they can suddenly go develop acute AR due to sudden valve dehiscence. So these are, even though rare, but we have to have understanding how it happens. So what are the hemodynamic effects of acute AR? So thing is, now if you develop acute AR, not as compared to chronic AR, LV is not dilated. In chronic aortic regurgitation, LV is dilated. So in acute AR, the apex beat is normal position. The reason being is acutely developed AR, and the patient did not have enough time to dilate the left ventricle. So there's an increased stroke volume and widened pulse pressure not seen as compared to chronic AR, because patient doesn't have a good volume in the left ventricle, like in a chronic AR. So the forward flow is less, and also the pulse pressure that you detect, that high pulse pressure in chronic AR is not seen in acute AR. So there's a decreased stroke volume, is compensated by tachycardia, and patient is tachypneic, and patient can go into pulmonary edema. The reason is the LV end diastolic pressure rises. When you get acute AR, there's a backward flow and the LVEDP rises, then the LA pressure rises and the pulmonary venous pressure rises. Therefore, patient develop pulmonary edema. And on examination, these patients are tachycardic, and there will be a soft first heart sound, and there can be a faint murmur, sometimes short diastolic murmur. So actually, clinically to detect acute AR sometimes can be difficult, but you have to have a good suspicion that patient has a acute AR. So as will lead to a rise in LA pressure and rise in pulmonary venous pressure, will lead to pulmonary edema. And also prematurely, it can close the mitral valve in early diastole because of the regurgitant flow. and patient is tachycardic, and they go into hypotension and cardiogenic shock. So it's an acute AR. Now you know the pathophysiology, and they can present with cardiogenic shock and hypotension. It can be in the emergency or it can be in the ward, but then we must know how to manage this valvular emergency. So clinically, there's a presentation is sudden cardiovascular collapse because of the acute onset of AR. There can be weakness, lethargy, sort of severe dyspnea, and patient is hypotension and very ill, tachycardic. So now this is a patient who was in the ward, and you can see, I don't know whether you can see my highlighter. Can you see that, my pointer? Right. So there's a the aortic valve endocarditis. This is a transthoracic echo, and there's a vegetation that is jutting up and down to the left ventricle and to the aorta. And you can see all of a sudden, actually, patient has become, while in the ward, has become dyspneic. And this is a toe image second, and you can see there's a AR, and patient is tachycardic, right? And that is of the endocarditis, right? So that is one of the causes I have mentioned, one of the etiologies. This is another patient who has present with backache and hemodynamic collapse. And then echo was done. Actually, this is from the phone image from the emergency while I was working in Karapiti. You can see the dissection flap. And this is the other, you know, the AR, and there's a large aortic root involved in the aortic valve. And this patient was, in fact, very ill looking. And that's the dissection flap. So, as I mentioned, the infections of the valve can go into acute AR. And also the patients who have dilated aortic root, sudden dissections can involve the aortic valve and can get acute AR. In addition, the valve dehiscence that I have mentioned and also trauma are the etiologies of acute AR. So how do you diagnose? So these patients are diagnosed clinically with the clinical symptoms and also the quick examination. And the chest X-ray PA, if you do, they have the normal size LV. And sometimes you can't send these patients for X-ray because they are sick. And if you are able to take X-ray, of course, they have a normal size left ventricle, not as compared to chronic AR where they have a dilated left ventricle, dilated heart. So enlargement of left atrium can be seen because of the increased LA pressure, because of the rise of LV EDP. And also patient can have pulmonary edema features on the chest X-ray. And prominent aorta can be seen sometimes in patients, especially who have aortic aneurysms and aortic dissection. And the gold standard way of diagnosis is echocardiogram. So in the echocardiogram, you can see the acute AR. At the same time, sometimes you can see the etiology as well, like aortic root dilatation, whether there's a dissection flap, whether there's vegetation of the aortic valve, all can be detected by a proper echocardiogram. Sometimes if you don't put Doppler, sometimes you can miss. If you just go by color flow, you can even miss in acute AR. So you have to be very careful and carefully look into the aortic valve, whether there's an acute AR. So having said that, so how do you manage these patients? So acute AR is there's like the only treatment is you have to do early surgical intervention and try to do a early aortic valve replacement. But these patients do not present all the time for tertiary care hospitals. They can be present to Valvular centers like Trincomalee. So they can present to various places where you don't have the immediate cardiothoracic backup. But then what we must do on those patients before we send for surgery? So we have to stabilize them. So what are the ways of medically stabilizing them? So you have to start intravenous positive inotropic agents like dopamine and dobutamine to maintain the blood pressure, and also the vasodilators. Now the way is you have to reduce the mean arterial pressure, mean aortic pressure. If you lower the mean aortic pressure, then the forward flow increases from the aortic valve. Therefore, it increases the tissue perfusion. So in fact, even the pressure is low, you try to start nitroprusside to lower the aortic pressure to increase the forward flow. And remember, even though patients are tachycardic, you don't start beta blockers. in acute AR. If you start beta blockers, what happens is patient become bradycardic and the diastolic time increases. If you increases the diastolic time, there'll be more AR. There's more acute aortic regurgitation. So you do not suppress by giving beta blockers. You don't give beta blockers in acute AR. At the same time, even though the pressure is low, you don't put intra-aortic balloon pump, which is contraindicated in acute AR, even though the pressure is low. Reason is, as you know, intra-aortic balloon pump, the balloon is inflated in diastole. So that when the diastole, the balloon is increases, the regurgitation increases. So you don't put balloon pumps in patients with acute AR. So roughly, if you have a patient with acute AR, so always you have to aim for early surgical intervention, acute, we have to do early AVR, and also medical stabilization. You try to reduce the mean arterial pressure, mean aortic pressure by giving drugs like nitroprusside, and you give the inotropic agents to maintain the blood pressure like dopamine and dobutamine, and you don't start beta blockers, and the intra-aortic balloon pumps are contraindicated. So the next valve is acute MR. So to know the acute MR, as you know, the mitral valve is apparatus. It has 4 components. Mitral valve has the valve leaflets, the valve annulus, the chordae, and the papillary muscles. So any pathology involving all these structures that can cause acute disturbance can result in acute MR. Suppose if there's a sudden chordal rupture, then patient can develop acute MR. And suppose there's a papillary muscle rupture or papillary muscle detachment due to ischemia, and they can develop acute MR. And these things can happen due to endocarditis, due to vegetations, your valves can perforate, or even ischemia like non-STEMI even can cause acute MR because of the papillary muscle rupture, even STEMI. Suddenly, while in the ward, a STEMI patient can become hemodynamically unstable because of acute MR, because the chordae can rupture, or even the papillary muscles can detach and cause an acute MR. And malfunction of a prosthetic valve. Similarly, like I mentioned about AR, similarly, malfunction of a prosthetic valve can cause acute MR, especially post-op immediately. The valve switches can delay and they can develop acute MR. So any problems in the valve leaflets, the tendae, and the papillary muscles, either it can be a vegetation, either can be a ischemia, or it can be a valve dehiscence after a valve replacement can result in acute MR. So this is actually a patient, when I was in foreign training, this patient actually came with cardiogenic shock. As you know, you can see the patient's heart rate is 114 beats per minute. And these echo images that you can see that there's a MR, but you can see that the LA and LV is not dilated. Similarly, like acute AR, the reason that it's not dilated is acute onset MR, and the patient did not have time to dilate the ventricles as well as the atria. So you can see very clearly there's a partial chordal rupture of one of the mitral valve, and then you can see an acute regurgitation of blood to the left atrium. And before the surgery, actually, this patient has undergone angiogram, and this is the right coronary artery, which had a very critical stenosis in the RCA proximally. So the reason is for this is the papillary muscle dysfunction resulting in chordal rupture of the posteromedial papillary muscle. You know, there are 2 papillary muscles in the mitral valve, one anterolateral and the other one is posteromedial. So which is supplied by the posteromedial, which is supplied by the right coronary artery most of the time. So there's a ischemia which has caused sudden detachment of the the chordae due to ischemia, which has resulted in acute MR. So now you know what is acute MR, you know what are the etiologies of acute MR, and what are the hemodynamic effects of acute MR. So, as you know, because of the acute mitral regurgitation, there's a rise in LV-EDP, left ventricular end diastolic pressure. And there's a rise in LA pressure because LV-EDP is equivalent to LA pressure. And there's a reduced cardiac output because there's a lot of blood regurgitating into left atria rather than going through aortic valve. So there's a reduced cardiac output. And because of that, there's a compensatory tachycardia. When there's a cardiac output less, there's a compensatory tachycardia, try to improve the cardiac output. And patient is hypotension, obviously, because of the acute MR. So what is the aim of treatment? So aim of treatment is we have to plan to increase the forward flow through the aortic valve. Try to decrease the regurgitant flow. We have to aim to increase the forward flow through the aortic valve. So how can we increase the forward flow through the aortic valve? And we have to reduce the afterload. And similarly, we have to reduce the mean aortic pressure. If you reduce the mean aortic pressure, then there will be more blood pumped from left ventricle to the aorta. And our aim is to lower the aortic pressure. Even though the pressure is low, still in acute MR, we try to lower the blood pressure. So we can start drugs like nitroprusside, small dose, try to lower the aortic pressure, thereby increasing the forward flow. And here, in patients with mitral regurgitation, acute MR, we can put intra-aortic balloon pump to increase the diastolic blood flow, and which will increase the tissue perfusion, at the same time, which will increase the coronary perfusion. However, these measures are taken to initially stabilize the patient until the urgent surgery is done. So these patients are, urgent surgery is needed. If you don't do early surgery, then they can die. So how do you medically stabilize these patients before you take, before the surgery is done, or whether, until the trance is organized? So our aim is to reduce the afterload. And reduce the afterload, we have to start the nitroprusside, like nitroprusside, which will reduce the aortic pressure, increase the forward flow from the left ventricle to the aorta, rather than it will decrease the regurgitant flow. And intra-aortic balloon pump is one of the key elements. If you have, you can use it. So definitive treatment is nothing is surgery, which has to be organized early as we can. So having talked about regurgitant lesions, acute AR as well as acute MR, the stenotic lesions also can present with like acute emergency. Like I have mentioned earlier, mitral stenosis and aortic stenosis. So let me first speak about critical mitral stenosis. So in patients with critical mitral stenosis, they do present can with effort dyspnea. First presentation can be pulmonary edema, florid pulmonary edema. I have seen many patients who has present with florid pulmonary edema. And also they can present with cardiogenic shock because there's no forward flow. Because of the critical mitral stenosis, they can be hypotensive, tachycardic, and they can have pulmonary edema. But remember, they don't have left ventricular failure. And it's a wrong misnomer that people say left ventricular failure. There's no left. Because pulmonary edema can occur because of mitral stenosis as well as ventricular failure. Here, the pulmonary edema is because the valve is tight in the mitral position. Therefore, the pulmonary venous pressure rises. So therefore, patients develop pulmonary edema. But their left ventricle is normal. So they develop pulmonary edema, not the left ventricular failure. So this is a patient. You can see one of the patients were presented with a florid pulmonary edema. You can see there's a mitral valve, very tight, and there's a spontaneous echo contrast in the mitral valve compared to the left ventricle. You can see the LA. There's a smoke in the left atrium. It's almost blood is trying to get stagnated and clot. And this patient actually came with critical MS with pulmonary edema, and one of the pregnant patients, and we had to take him to her to cath lab and did a emergency mitral valvulotomy. And after that, you can see the patient is better, than mitral valve is well opening, and the LA, the smoke has disappeared, and patient has become clinically better. So this is a 24-year-old patient, pregnant patient. Actually, this patient I got when I was a senior registrar working in cardiology unit NHS. This patient was referred from Castle Street Hospital with a P1C non-pregnant mother with a POF 28 weeks, presented to obstetric unit with a severe shortness of breath. But up until then, patient had some effort dyspnea, but 28 weeks, that's the time they present. And that's the time there's a cardiac output rises. And then, pregnancy is a very good stress test, and pregnancy, even the moderate mitral stenosis, they can become very symptomatic when they go through the pregnancy. So this patient present with the sudden breathlessness, and tentative diagnosis of pulmonary embolism was made, which was correct, because any patient period of when they are pregnant, one of the diagnoses that you have to consider, if they come with hypotension, breathlessness, you have to think about pulmonary embolism. But however, patient was tachycardic, hypotensive, and echoed and showed severe MS and favorable valve score. So she had severe breathlessness and pulmonary edema, and she was reasonably stabilized with PTMC, was carried out after successful stabilization, which I have showed you earlier. So how do you manage if you get a critical MS to the emergency with pulmonary edema? And patient can be tachycardic, patient have pulmonary edema, and then how do you manage? So of course you can give IV Lasix bolus and even infusion after giving the bolus, because we have to get rid of the pulmonary edema that is there in the lungs. So you can give a Lasix, and you can put the patient on a CPAP just to make them better and to reduce the pulmonary edema. And as compared to patients with heart failure and pulmonary edema coming due to left ventricular failure, patients with mitral stenosis, critical mitral stenosis coming with pulmonary edema, we have to give rate limiting drugs. Suppose the heart rate is 160, we have to bring the heart rate down quickly. Then they will become better, because by lowering the heart rate in critical MS, you increases the diastolic filling period. Therefore, the left atrium to the left ventricular filling increases by reducing the heart rate. So even though patients are so sick, we have to give beta blockers, or if the beta blockers are contraindicated, even calcium channel blockers, even sometimes we have to give IV beta blockers to get their heart rate down. Even though they have pulmonary edema, they will become better. And once you have hemodynamically stabilized them, getting out of pulmonary edema and having CPAP and giving the rate limiting drugs, and then you have to think about doing emergency PTMC. There were instances that I in my life, actually, I have done about 7 to 10 emergency PTMCs who has come to actually 4 patients were actually from obstetric units. And emergency PTMC need to be done. Emergency means at least early you have to do it after stabilization. And of course, if the patient's valve is not sorted, then you have to do the open surgery with the mitral valve replacement or open mitral valvulotomy. But if the valve score is not good, of course, you have to do for mitral valve replacement. Just for the interest's sake, this is a patient who had present with breathlessness, but there's no valve problem. This is a patient who had a large atrial myxoma. You can see the whole, it's occupying the left atrium, but patient was a bit of hypertension and tachycardia. That's what I showed you, but these are very rare conditions, but though it can happen. But there's no valve problem here, right? It's just the left atrial mass that is, causing problems to the cardiac output. So, valve thrombosis and valve lesions. So, let me talk about this patient. When I was at Karapiti, this patient was referred. She was a 32-year-old married lady with a mechanical mitral valve. And this patient was referred for cardiac assessment prior to pregnancy. She had a mechanical mitral valve. You know, mechanical valves are very difficult to manage during pregnancy. And an echocardiography done showed normally functioning mitral valve prosthesis with good LV and RV function. And she was given anticoagulation with warfarin 7.5 milligrams daily. Since the INR, since his warfarin dose is more than 5 milligrams, actually the patient was switched to enoxaparin by the hematologist. And however, the dose that was prescribed by the hematologist was 60 milligram enoxaparin subcutaneous daily, where the body weight is 50 kilograms, but it has to be ideally 1 milligram per kilogram BD dose. So after 9 weeks of POA, she got chickenpox. And 11 weeks of POA, she presented with worsening breathlessness. So what are your differential diagnosis? This is a patient who had a mitral valve replacement and given a subtherapeutic doses of enoxaparin, right? And coming with breathlessness in 11 weeks of POA. She was hypertensive, tachycardic, very ill looking. And she had a chickenpox at 9 weeks. So we actually initially thought the patient is having, chickenpox pneumonitis. But after, exploding, we did a sudden echo and realized that this is what patient had. This is the echocardiogram. And this is actually toe image, right? And patient has a valve thrombosis. The valve was thrombosed. So this is a valve emergency. If a prosthetic valve becomes thrombosed, what can happen? It behaves like similarly like a critical mitral stenosis. So when the valve is blocked, that the blood flow disturbed, going from left atrium to left ventricle. So it behaves like a critical mitral stenosis. You can see the pressure gradients, which are very high across the mitral valve prosthesis, and patient had a large thrombus in the mitral valve, impinging and disturbing the valve opening and closure. Therefore, patient was tachycardic and hypertensive. So how do you manage valve thrombosis resulting in clinically like a MS? So how do you manage? What treatment modality is available? So can you give thrombolysis during pregnancy? Of course you can. But of course, it's a relative contraindication, but cautiously in a tertiary care unit, in a CCU monitoring, you can start. So this patient was given IV alteplase for 24 hours, followed by IV heparin, and patient breathlessness improved, and the echocardiogram done showed the following day, immediately the following day, normal, and then the pulmonary hypertension has come down, and all the valves are opening, and the gradients have markedly come down. And the toe images had showed normal. So this is a clear example. Even the valve thrombosis can present with the valvular emergency. So you have to have a good clinical suspicion on these patients. So I talked about tight mitral stenosis, the critical MS. So there I talk about the various ways that they do present, and also a rare example of where the valve thrombosis can present with the critical mitral stenosis. So next is my last part of my talk is tight AS, tight aortic stenosis or critical aortic stenosis. They also can present with pulmonary edema with LVF and can present with cardiac arrest or syncope. Severe symptomatic aortic stenosis has a 50% annual mortality. Actually, in Sri Lanka, we are doing very bad on aortic stenosis. And we think that our coronary artery disease burden, we treat him by coronary artery disease. Most of the coronary artery disease actually can be managed medically. But aortic stenosis is really a killer. If you have symptomatic aortic stenosis, if you don't do surgery, there's a 50% chance that that patient can die in a year. So these patients who are living, who could not get done their valve replaced, because it's very difficult to get a valve replacement in Sri Lanka. There's a lot of waiting list for valvular replacement, especially like tight A's. And they can present to you in the emergency, like sometimes can be a cardiac arrest can be the presentation, or can be syncope, hypertensive, can be the pulmonary edema, can be the manifestation. So these patients can present like that. So how do you manage? Of course, if patients come with pulmonary edema, you can use diuretics and treatment of concomitant hypertension to minimize the pressure overload to the left ventricle. Now, this is also a very important thing. Now, because of the aortic stenosis, the left ventricle is pressure overloaded because left ventricle cannot pump blood because there's a resistance in the aortic valve. But if you have concomitant hypertension, there will be added burden to the left ventricle. In addition to the aortic stenosis, when there's a hypertension, there will be added burden to the left ventricle. So you try to reduce the aortic blood pressure. Therefore, the pressure overload get less. And patients who present like this, sometimes it's very difficult to organize emergency or early aortic valve replacement. It's one of the most difficult things that we could organize in the government sector. So as a bridge therapy, we can do aortic valvuloplasty as a bridge therapy, which will take some time. Aortic valvuloplasty is where basically you put up a balloon across the aortic valve, like PTMC. You dilate the aortic valve, try to improve the, try to reduce the aortic valve gradient. But it is not a definitive therapy. Patient need to go for AVR in the future, but it has a bridge therapy to get rid of the acute situation. But unfortunately, the countries like ours, we do rarely do few cases of TAVI, where the percutaneously patients who have high valve score, patients who have high risk for surgery, we can do a transaortic valve implantation percutaneously. Unfortunately, still is not available for the public sector in Sri Lanka, but hopefully in the future it will, hopefully. And the main surgical management is basically surgical aortic valve replacement. So thank you very much. So I was talking about so far the valvular emergencies. So I talk about various ways that the valve emergencies can present, and there are etiologies and how you medically stabilize them, and what are the definitive therapies you can do to these valves. Thank you. Any patient has pulmonary edema, you can use CPAP, right? Initially to stabilize, right? Not only in mitral stenosis, but I particularly mentioned mitral stenosis because mitral stenosis is the one that really comes with pulmonary edema, right? And especially in florid pulmonary, but in other cases also you can use it, right? But basically, most of the time we use in pulmonary edema with mitral stenosis and also LVF, and other cases also, other patients also you can use it.
Okay, thank you, sir.